doing that, I'm going to go ahead and think about the first question here. There seems to be a bit of people want more details. What can they have when they're fasting? What can't they have? Water is okay. Typically, coffee, tea, and are okay. But how about coffee with stevia or coffee with cream? Where do we draw that line? Who wants to take that one?
I can take that one. We have generally do the following. So we
I did
generally
it.
say if there's appreciable calories that it would be off limits during the fasting period. So for us, a squeeze of lemon is totally fine. Chewing gum is fine. Diet soda is fine, though certainly not our first choice. We would say coffee with cream is not allowable. And we would draw the line there. We have done it either way in terms of allowing coffee outside the window versus not. It really just depends on the study protocol. I understand the research community is split on whether coffee should be in the eating window or not. We've worried a little bit less about it. And then in general, most of our studies were trying to isolate the effects of intermittent fasting independent of diet quality. So we generally tell people keep doing what you're doing. And so we've generally counseled folks to eat, just keep carrying on their usual habits. And then I will say, because the eating disorders presentation by Dr. Hahn was so provocative. One of the things we've done that I think has been beneficial for folks is that we generally tell them not to skip meals, which I feel like could be an important strategy for reducing the risk of developing eating disorders. So we just counsel them to eat the same meals, but in a shorter time frame. So
Yeah, I would add
that is
that
helping. Yeah.
that also aligns with the circadian data, right?
Yeah.
It's about having that rhythm of
Yes.
foods, and the random skipping can do almost as much
Yeah.
harm.
Yeah, exactly. I start worrying about that. And I also worry a little bit about these 1 meal a day approaches as well, where people try to eat everything 1 meal a day. And I think even though we don't have good data on this yet to say either way, but I worry that those also might impair protein synthesis.
Yes, I also worry about that very much so. And we have Dr. Kogan joining us, who's a geriatrician, who I'm going to guess also has some concerns about that. Do you want to weigh in?
Yeah, so I think when we're looking into a more older population, I think the risks are even higher, right? I think all of the studies that have been done, very few have looked at people over 65. I think Courtney, I was keeping very close attention to your presentation because you presented so many studies. I think there was one that specifically looked to the older adults, but it was a small study. But I think the risk of sarcopenia, muscle loss in that group is even higher. And thus, I think we need a lot more data to say sort of what is safe, what is not safe. Generally, my position is probably 14 hours during the nighttime. Every night is safe enough, as long as you don't cut the calories. But going beyond that, I would be hesitant to recommend to a lot of people. Now, of course, there's a difference between 65 and 65, right? Somebody at 65 could look like 45, and somebody at 65 could look like at 95. We see all this. So it's not to be averaged here. It's really more of a general statement, I think.
So you mentioned sarcopenia. There's a question here. Could the increase in function in senior patients who practice TRA be a function of improvement in their sarcopenia, which has a strong metabolic component and consequently improves and the improved reduced insulin?
I think this has more to do with often sarcopenia is linked not just to sugar, but also to inflammation. Right? So if we know that we can control inflammatory response with the TRA, that or at least be part of the treatment for the inflammatory response, then that's probably going to be beneficial.
Absolutely. So similarly speaking, we got a question here from Dr. Brad Moore with the Lifestyle Medicine Clinic here at GW. How does lean muscle loss compare across the different styles of fasting? Are they pretty comparable, or do we see a difference? Courtney, could you answer that one?
Sure. In general, a lot of these studies find no negative effects on lean mass, but I suspect a lot of that's due to the sample sizes or the duration and this is across a very wide variety of intermittent fasting approaches. I think it was James Bett in England, Bett's recently in England, where I think he tried 36 hours of fasting on an alternate day basis. So I think it was roughly about ADF. And I believe they did see negative effects on lean mass within 3 weeks. Now, I don't think they used the most sophisticated methods of assessment where you can even tease out, how much of the effect is due to changes in total body water versus actual changes in, I guess, the non-water component of lean mass. So they didn't go that far with sort of these four, I forget the exact word, but like these more sophisticated ways of parsing body composition. But I do think that is cause for concern. And I do worry about some of these more extreme forms of intermittent fasting in the long term, where you are having these 24-hour only fast. And I will say, I mean, I know we're supposed to talk only about science and not about anecdote, but there are a number of intermittent fasting influencers who said, hey, look, I did take the fasting too far and I lost too much lean mass with these extended, 2 to 3 day fasts, or frequently doing, 1 day a week fasting.
Want to put a shameless plug to our geriatric team. We're actually doing a study on sarcopenia using a brand new method, which is different from standard. So if anybody's interested, I think I'll put the link. I'm not a PI, but a good close colleague in geriatrics who's a co-PI. So it's a collaboration between geriatrics and engineering at GW. So if anybody interested, you'll get a free testing. I don't know if
There you go.
You may even get paid, but I'll put the link.
Excellent. Thank you for sharing that. Another thought that popped into my head too is, and you're hearing a lot about this with the GLP-1s, is when people lose weight, they lose lean body mass. It's by design, right? They were carrying this weight around and now they don't need to carry that weight around. So there is going to be some sort of shrinking. So even if there is a reduction, the question is that a harmful reduction or not? And there is definitely a level at which it's not harmful, and there's a level at which it is. And so you need these sophisticated tools to really be able to answer that. And I haven't seen any study that has looked at that. All right. So another question we have here about is the effect of TRE on hypothyroidism. For instance, any reason why someone on levothyroxine should not do TRE? Anyone want to take that one? Not my area.
There's not a lot of data on it. I think there's maybe only one secondary analysis of a clinical trial, and I believe there was no change in the thyroid hormones that were measured in that trial. Maybe there's two, but there's not a lot of great data. I don't have any particular concerns about it, but I'm also not an MD.
Right. We do have two MDs on the call, but I don't know if this is either Dr. Heyman or Dr. Kogan's bailiwick.
I haven't seen anything, and I have a lot of people on intermittent fasting. I would say, I don't know, Andy, if you've seen anything, I haven't seen any real effects. I think you do have to be careful with adrenal system, I would presume, but again, we do this in such a carefully observed and controlled settings with monitoring that probably not seeing.
I've only heard conjecture that, prolonged avoidance of carbohydrates, potentially can affect T3 levels, but I haven't seen it, honestly, in my practice, quite frankly. I think the benefits far outweigh the risks.
Especially if you're being monitored like they are in your clinic.
Correct. Mm-hmm.
Right. Yeah, so I think that comes down to a lot of these questions. It's going to be how intense are you monitoring them, and are you working with them very closely? Then you can be a little bit more aggressive with these things. And hopefully you are also monitoring them for eating disorders so that they are not developing those. Let's go down to, there was actually a lot of questions about the eating disorder section. So I'm going to pick some of the big ones, and then maybe Dr. Hahn, you can answer some of them independently. What research has been conducted to identify at what point the risk factors become riskier as opposed to being reversible?
That's a great question. There hasn't been any research, to my knowledge, looking at kind of identifying what is a maintenance factor in particular, versus a risk factor for eating disorders in this population. So I think it's just acknowledging that folks who are going to be recommended intermittent fasting are baseline high eating disorder risk. And we just have to acknowledge that and screen for that and continue to rescreen, right, for eating disorders. And at this point, we really can't say what is a maintenance factor, what is rescreening, or causing eating disorders to be worse in this population, etc. I think it's just kind of the research isn't there yet, unfortunately.
Unfortunately, I think that's going to be true for a number of these questions because it is an emerging area. One of the points that I think maybe is not clear is exactly what do we mean when we talk about this eating window, right? Is 6 better than 8? Is 8 better than 10, 12? Where do we draw these lines or lines? And then do they have to be consecutive? I also got a question on that. Like, can you skip breakfast and dinner but have lunch? Or can vice versa? Can you skip breakfast and dinner or can you skip lunch but have breakfast and dinner? Is that enough to have some fasting benefit?
Yeah, I will answer from the eating disorder perspective in terms of what is high risk and what we consider problematic. And what we consider problematic is that feeling of deprivation, right? So being hungry and not eating, or being
Mm,
hungry and saying like, I'm not going to eat because I want to lose weight. That's really kind of the problematic sticking point for us rather than um, a specific amount of hours. We do consider like 8 or more waking hours as fasting and disordered eating, but because I think we can all agree that somebody who is awake for 8 or more hours is going to be hungry. And disordered eating, folks who experience disordered eating oftentimes have dysregulated hunger and fullness cues, in particular, folks who engage in intermittent fasting. They're used to prolonging their hunger, right? They may be hungry in the morning, but they're not eating breakfast, they're not eating lunch, they might not eat until dinner or what have you. So they're used to prolonging that. And we can't necessarily rely on their hunger and fullness cues in the same way that we can in a quote unquote healthy individual. So dysregulation and kind of saying, even though I feel this, I'm gonna ignore it.
yeah, I love that. I'm all about listening to your body. I promote that all the time, but you make a valid point that your body may not be able to tell you if you are,
And I'll jump in
not
and
listening to it.
answer. I'll jump in
Go
and
ahead.
answer the second half of your question there about the skipping meals. And that goes back to Dr. Peterson, and she showed that nice metabolic graph of the different fuels in the body. And I think that really answers a lot of that question of the metabolic side. So if you go 6 versus 12 hours, there is a difference metabolically in the fuels available and what your body is trying to do. Is it trying to make its own glucose, for example? And is it turning on signaling mechanisms that do that turn on autophagy that we heard about earlier and stuff like that? So there is a benefit to going longer, and the research has shown that to an extent. I think that's what Dr. Peterson kind of strongly recommended, that 14 to 20 hours. If you break that fast by skipping breakfast, eat lunch, skip dinner, or whatever variation you want, then that's kind of disrupting that normal feel of that body. It's restoring exogenous glucose and fuels to your body and changing the signaling in your body. So when you do a fast, it's really that time of the fast is really where a lot of the benefit comes from metabolically. So there is probably some research, Dr. Peterson can jump in and tell me if some little micro fasts are good. And they probably are from a calorie restriction side, but not necessarily from a metabolic fasting side.
Good distinction. I can anchor that a little bit further. So I'll say the data on 10-hour eating windows is more mixed. We don't see a consistent trend with body weight. I mean, when you look at these meta-analyses, they pull them over windows up to 10 hours long. So net effect is, yes, it reduces body weight. But if you look at the literature in it with 10-hour windows, it's about half of studies find a benefit and half don't. I recently saw a study that compared 10-hour versus 8-hour, and they found a larger weight loss benefit, which is perhaps no surprise with the 8-hour window. I will say, in my experience, I have run experiments with 6-hour windows. We find that once we get to 6 hours, patients actually don't really like going much lower than 6 hours because they feel really stuffed. And actually, once the eating window gets that small, they find it more the actual eating portion of the day to be more challenging from the fasting portion of the day, because it feels a bit like to them like they're eating Thanksgiving dinner every day, because they're just compressing all their eating to a short time period. So I don't generally recommend less than 6 hours. That would be kind of my limit, or at least in the absence of more information that it's safe from both a metabolic perspective as well from an ED or eating disorder perspective as well. So for most people, if this is appropriate to you, I recommend the 6 to 10 hour range. I recommend start at 10 hours, then work your way down if comfortable. If not, stay where you are.
I provide similar advice. I typically say aim for 10, particularly when I talk to seniors. I don't push them much beyond 10. But another group that could be of interest, there's a question here about the evidence or data on perimenopausal and postmenopausal women and women with genetic predisposition for breast cancer. Those are two questions, but I think we could just talk sort of generally about women's health and how fasting may affect women differently. Anyone want to take that one?
I can take it from a eating disorder
Great.
perspective. So as I mentioned in that bimodal curve, that is a peak period for disordered eating, in particular because women's bodies are deviating during this period from what is considered culturally attractive, right? Women are experiencing a hormonal shift that is really positioning them to have adipose tissue directed around their midsection, which is not what we consider conventionally attractive. And then also just more generally, their metabolism slows down, right? So women in this period are really trying to fight their biology to try to lose weight. And it's also a period where we see increases in type 2 diabetes, hypertension, all of these types of things where intermittent fasting might be recommended biologically for good reason. So I would say from IF eating disorder perspective, it is biologically makes sense, but it is very much socioculturally driven in terms of if we did not have these ideals, if we did not have these unrealistic beauty expectations of women and also of men, but particularly women, we would not be seeing these high rates of doing anything that women can to meet these unrealistic beauty expectations, including IF for those that IF is not recommended for.
Great, thank you. That was very helpful.
I can chime in too. There was a study that was just published in January in Nature Medicine in about 200 people. And one of the main goals of the study was to see if there are any major differences between men and women. And they didn't find any, which is interesting because in the animal literature, there are a large enough number of differences between male and female rodents that are intermittently fasted, but I'm not sure we're seeing any large effects in people, but who knows? We'll see. I mean, it's still a young field.
Yeah, I agree. And one of the things that pops into my mind when I hear it is similar concerns to seniors and people just generally. Are they getting sufficient nutrition? That would be my chief concern. And if they're, working with an RD or a CNS and making sure they're getting enough nutrition, then I'd be less concerned about that. But it's always going to be a problem with IF is, are you getting enough nutrition? There was a question here about people who are having trouble keeping weight on. And there are many metabolic benefits to this, but if you are someone who's naturally lean or maybe even too lean, is this a technique you should avoid?
I can probably speak a little bit to that since I deal with this all the time in clinical settings. So the way I sort of suggested the two things. So first you start with under the 14 hours, like 12 hours, and then you very slowly progress it. And you also always take some extra protein early with the first meal. I'm not calling it breakfast, just the first meal of the day. And then if the weight loss begins or starts, then sometimes I would just say, yeah, you have to stop. I mean, this is especially in people who are to begin with more metabolically fast. Sometimes I would even assess some laboratory tests. So there's a way to look at the Krebs cycle, and if I see that the Krebs cycle seems to be fine and there's not a lot of glycemic issue, they just want to lose. They don't want to lose weight. They're doing this, for example, as part of our brain program. So we give them these parameters and we monitor them weekly, their weight. And if we start seeing loss, we start getting worried and we either try to modify it. And if we can, then they just get off of it. This happens. And we're not necessarily monitoring the muscle mass. We're just monitoring total weight. And we're making sure it doesn't drop below, certain BMI.
I don't have any
thank you.
experience in this area, but I will say on the broader picture, I don't believe intermittent fasting is for everyone, despite what it might seem like. I do believe there's something in there in regards to meal timing for everyone. So for instance, simple rules like don't eat 2 hours before bedtime or 3 hours before bedtime, I think can still be really helpful for folks. And we find there are plenty of folks that are in occupations that don't allow them to do time restricted eating, or at least not so easily. It makes it much more challenging. And in those cases, there are other options too. I mean, to the best of our knowledge, there are benefits from eating earlier in the day, at least in terms of blood pressure and glycemic control. And so I'll often tell our patients who, can't do intermittent fasting, like, hey, you can still, if I were to give you another simple rule to follow, it would be make dinner the lightest meal of the day and make breakfast and or lunch the largest meals of the day. So just some thoughts there about, I think in the long term, we do need to customize this for individuals. And we have some data that'll be coming out soon that we find people are so interesting and varied in how often they want to do intermittent fasting. So even in our studies, we'll report a mean number of 6 days a week, but we find there's some folks who feel like they want to do 7. And when we say, oh, well, you really can do 6 and take a break day a week, they say, no, I don't want the break day. I'll fall off the wagon. And they feel very strongly about that. And then we have other folks who are like, I can do this if I only have to do it 4 or 5 days a week. And that's my limit, 5 days a week. And so I think it's important to really understand that we need to kind of meet people where they are in their life circumstances. And there's definitely no one size fits all.
Yeah, and I would add, I think that's one of the benefits of the fasting mimicking diet is you only have to do it 5 days a month.
Exactly. Exactly.
We found in our mold and Lyme population that about 80% of them, based on their transcriptomics, they're in aerobic glycolysis. And it's not a great strategy in the early phases of treatment to put them on a fasting regimen. It's not until we clean up their environment, reduce inflammation, and as they shift into oxidative phosphorylation, then they can sort of sustain the fasting state and burn energy appropriately. But what we find, if they don't do that, they crash. And, we run into trouble. So I tell them overall it's a good idea, but I have to sometimes hold them back from, wanting to go into the fasting state a little early in the treatment process. It's a unique population, but it's not an uncommon one, at least in our field of integrative. And so, I would caution practitioners who might be seeing mold and Lyme patients, be a little ginger with that group in particular, because they can really get into trouble if they try fasting and they fall into that kind of push crash phenomenon.
And I would generalize it to anybody who's really toxic, probably should be super careful. Like, should just really not start with that. Like, you should really figure out why you're toxic, get your mitochondrial health a little bit better before you sort of jump on this, because we see complications quite frequently. And crash is a right term. It's exactly what happens. They crash. They just get much worse for a period of time until you make them support them a bit more.
Yeah.
I think I have the perfect follow-up question for this from one of our integrated medicine students, actually. How do you best advise healthcare professionals to practice harm reduction techniques if they have someone who's not a good candidate for IF but wants to do IF? Like, they're going to do it. How do you help them reduce the harm?
I'd monitor them a lot more. If I know they're gonna do it anyway, and I want to keep them, and I want to have that relationship, I would probably just be very aggressive at monitoring.
Yeah.
To
And
testing.
Wait. Sort of to Misha's end, I mean, I would say some of the kind of vital signs of toxicity, you'd want their anion gap to be less than 15. You'd want their urine pH to be above 6.3 or so. You don't want them too acidic, because if they're really acidic, they're going to run into trouble. And so there are kind of like a couple poor man versions of looking at that issue of acidity, and and therefore as a proxy toxicity. So I always measure their anion gap, and I'll do a urine pH. And so these are just kind of rules of thumb. This is, let me be clear, it's not evidence-based per se, although there's data around these subjects. But if you're looking for kind of a guide, because one of the things we all know is that there's sort of this bimodal distribution in our practice of medicine. You get a group that's relatively well and want to optimize, and as Misha knows, we also get the group that is unbelievably sick and unbelievably complicated, and you want to be incredibly careful with these people, because as he said, if they're toxic, if you push them, they're going to crash. So always make sure that they've narrowed their anion gap, their urine pH is not too acidic, and then I say, okay, maybe we can do some of these other things. Yeah. Just kind of pearls of wisdom and rules of thumb. That's all.
And I'll go back to the broader question that was in the chat. I think was really trying to dig down to like the risks of your patients, and the risks was really general, right? And I think, if you take those risks and compare the eating disorder with the actual risks we're talking about with acidity and pH and lactic acid production and that crash that they could have, there's two very different types of risks there. So it brings me back to you could ask someone, oh, do you exercise? And they will say, yes, I do. And you're like, great, you're healthy and it's a healthy person. But then it turns out they exercise for 7 hours a day at this compulsive level. Well, that's a whole different level of risk now. And it changes your mindset in relation to that patient's now risks, right? So with eating disorders, there's that risk. There's that risk that they could tell you, I'm going to do this behavior. And the more you learn, especially with your patient in front of you, then that has to change your recommendations to that patient and what things you need to look out for if you're still going to go forward with any type of prescription, whether that is IF or not.
Perfect. Thank you. So we are running short on time, so I'm going to go around and give last words to everyone. I'm going to go in the order of presentation. So Courtney, you are first.
I think my best last words were the ones about customizing this to the individual. So I think I'll just double down on this. So I think we are clearly seeing benefits for intermittent fasting for losing body weight, for improving cardiometabolic health, though perhaps not lipids, I would say, or at least not with intermittent fasting. And we're also starting to see evidence that it may slow the aging process. And certainly in animal studies, I didn't present this, we now have 4 animal studies suggesting that time-restricted eating increases lifespan. So I think the data is really exciting. The question is, how do we prescribe this safely and to what patients and for what conditions? And I think we found that adherence depends so much on behavioral circumstances. It's not, folks who have an early versus late chronotype or anything like that. So I think it's really important to get to know people and what they're willing to do. And if there are any risks, say if they're on an anti-hyperglycemic medication, there are increased risks for those medications. If there are risks for eating disorders or other sort of factors that are important, and then kind of work with the patient to customize the plan.
Great. Thank you, Jesse.
Yeah, so I think I just go back to the general principles of nutrition. That's kind of a theme we talked about, is that intermittent fasting is a strong tool, but we need to treat it as a lifestyle change, not necessarily just a tool that people can use it and then stop using it, use it and stop using it. I think it's much more of a long-term tool that if we as a society change our eating habits and structures around the principles of intermittent fasting, where it's okay to go longer periods of time without eating. We don't have to be surrounded by food. Our lives don't have to be built around a clock. It's noon, it's time to eat, that kind of stuff. And if we just learn to listen to our bodies, go longer periods when we of not eating, I think that can eliminate a lot of risk with a lot of health benefits.
I did skip myself, and I'm just going to reiterate what you said. That's fantastic. I'm with you. And Samantha, I'll give you the last words.
I think mine are just words of precaution, right? I think with every tool that we have in nutrition, I am an advocate of looking at potential harms, making sure that we are not just kind of giving blanket statements and saying this is a beneficial tool for all, but thinking about for whom this might be harmful. In particular for IF, the folks that we are giving this advice to are folks who are at high risk for eating disorders and disordered eating. So thinking about this from a more holistic perspective in terms of how are we advocating for IF, and is this actually potentially harmful for this individual? Just thinking about it more holistically in general.
Well, we are all about that in integrative medicine. So we are out of time. This was a fantastic afternoon. I really enjoyed it. Thank you all so much for joining us. We really appreciate your expertise and your time.
Thank you.
Until next year, everyone.
Mhm.